We're going to make a start. It's an early start, and who better can we have than Gina to give us the lecture on local imaging staging for rectal cancer. Gina is a professor of radiology at the Royal Marsden Hospital. We call her the Queen of Radiology in the UK, so we'll have to see what she has to say in terms of the staging. Hopefully we won't argue today. I do argue with her every Monday.
I think they enjoy this. Thank you, Paris. And yes, we do argue, but eventually we come to an agreement, and that's how we all learn. And it's a good thing. So, in case I don't get through all of this, because Prof. Zinos asked me to do everything in 30 minutes, so I may not get through it all.
The most, yeah.
So if I don't get through it all, most of what I'm talking about is on that website. And also, if you want to come on any courses, we have one that Paris and I do together, where we go through cases and discuss. Please look on the website, and you'll be able to come and join us. So if you look at some of the trials for the radiotherapy trials, and I think you've been hearing about them these last couple of days, you are met with a little bit of disappointment in that not a single one of these trials has been properly positive in terms of improving survival. And is it because the treatment doesn't work? Why do we keep seeing trials with curves like this? Every single trial, utter disappointment. Why are all these trials negative? Is it really because the treatment doesn't work? Well, I would argue that there are a few problems with these trials. And the reason really is that they included too many good prognosis patients. If you don't stratify the patients, then you're going to get a negative trial. And why would you get that? Because most of those trials, they're very, very loose in their description of who was included. Clinical T3, T4. Well, if you've tried to do that staging with a digital rectal examination to say, oh yes, I think it could be T3 or T4, you are going to have a flip of a coin in terms of accuracy. And so you can imagine who has gone into those trials, pretty much every rectal cancer. So some of those are extremely good prognosis, and some of those are not so good prognosis. What it effectively means is you're treating these patients in a trial unselectively, but worse than that, the good prognosis tumours are being overtreated to the point where they're harmed, because they will get worse outcomes than they would if they'd actually gone to primary surgery. And that is why you get a negative trial, because all the patients that benefited, because they were advanced, were outweighed by the ones that were good prognosis, that didn't need the treatment, but who actually had a worse outcome as a result. So I think we have to understand that you cannot just say T3, T4. You cannot keep saying that. And you cannot keep making strategies based on N stage. So all of these things has to change. And we now have evidence base for changing it. And so really it's not an excuse anymore to say, oh, well, we don't have MRI, we don't have this, we don't have that. We don't have Gina Brown, we don't have good quality radiology, because all of these can be fixed in the same way that you fix the quality of surgery. So what we are trying to say is that you have to be very critical when you're looking at your scans. Is the margin involved? Is the depth of tumour spread more or less than 5 millimetres? Is it really a T4? Is it really invading the next structure? What about the lymph nodes? How important are they really? Have you looked for that vascular invasion? And what about the rectal stage assessment down in the level of the pelvic floor? These are the questions, not this is T3, T4, let's irradiate. That's the wrong approach, completely the wrong approach. So we'll spend the next few minutes going through the actual evidence, because that's what you need. You need to be sure that when somebody says something to you, that actually predicts for something. So when an MR-CRM report says the margin is clear, the risk of local recurrence is the same as a pathology margin involved, or clear. So in other words, if we say margin is clear, 7% local recurrence, if the pathologist says margin is clear, it's 6.5% local recurrence. If we say margin is involved, 20% rate of local recurrence, 26% for path-CRM. So you can see that even though the MR and the pathology may not always agree, the risk of recurrence and the risk of not having a recurrence is almost identical. So that's something to bear in mind. And that's what we published in the JCO from the Mercury 1 study. We looked at the long-term outcomes and showed that MRI could predict for the risk of not just of local recurrence but also overall survival based on a single factor, which is tumour relationship to the mesorectal fascia. So you could argue, okay, well, if the margin is clear, there's no need to irradiate any single patient, just the ones that the margin is involved. Okay, so that may be the answer, but actually we have some more information about what other staging factors are a risk for recurrence. So MRI, if you have an involved margin at the beginning and you irradiate and the margin becomes negative, there are lives saved. We see that, so it's a prognostic and predictive biomarker. In other words, if you go from positive to negative, the patient takes on the characteristics that are the same as a patient who had a negative margin to begin with. So that is definitely worth a group that's worth treating. Now this group, so these are tumour spread with 5 millimeters or less. These patients do very well with primary TME surgery. You can be worried about this lymph node here, and it's sitting right on top of the margin, but that worry is completely unfounded, because there is no evidence on MR that any lymph node like this is going to cause you a problem in terms of recurrence. We couldn't see it in the Mercury study. We found many, many patients with nodes close to the margin, but not a single case of margin involvement or indeed recurrence as a result of a lymph node. So this is not the culprit, and this is not something to be torturing the radiologist about telling you if there's positive or negative. It's of no concern. It's actually quite a struggle for a surgeon to produce a positive margin from a lymph node, because what do they have to do? They have to go inside the fascia, get inside the lymph node capsule, spill tumour. It's just not going to happen. It's quite impossible. So for this reason, we do not pay any attention to nodal staging. And really, this is the point. And every single pathology series where they have measured the depth of tumour spread, which actually doesn't always happen, so that's another thing that should be done by pathologists, is where they've measured the depth of spread. If the tumour spread is less than 5 millimeters, whether or not the lymph nodes are involved, the outcomes are extremely good. And this is from a long time ago. This is from 2001. And actually, hundreds and hundreds of patients looked at in the German pathology registry, showing this piece of fact, which for MRI point of view is we can tell you this group of patients because our measurement of depth is much more precise than our assessment of lymph nodes. So therefore, if we identify a tumour with less than 5 millimeters of spread, it doesn't matter if the lymph nodes are involved, they're going to do well. So putting all of these patients into a chemoradiotherapy trial, you can see is going to cause damage. It's not going to help those patients. And what will happen is these patients, any positive effect will be lost. And that will happen in whether you do it as a colon cancer study or if you do it as a rectal cancer study. This is the group that need treatment. And so there's a difference in survival. And that's what we showed in the Mercury study. Those patients with tumour spread of less than 5 millimeters had a 1.7% local recurrence rate if they were T3B, less than 5 millimeters, and if they didn't have extramural vascular invasion, and it was regardless of the nodal status. So why is it that we still cling to Jukes? He was a great pathologist. He showed this beautiful piece of work which showed that Jukes C cases had only a 7% survival. But that was back then. That was in an era when TME surgery, this was before Bill came to teach everyone how to do the surgery properly. So of course, nodes predicted for bad surgery. In other words, if you rip and snatch the rectum, you're not just leaving nodes behind, you're leaving everything behind. And of course, nodes are just part of the process. And so when we look at our data these days, the Duke staging doesn't work for us. There isn't a good separation, as you know, between the positive lymph node patients and the negative lymph node patients. There's an overlap. Some of the so-called Duke's B patients are doing much worse than some of the lymph node positive patients. So we have to ask ourselves, why is that? And what else should we be doing? So Phil Quirk published this paper, but hidden in that very nice paper about margins and CRM status is this point here. And this is worth bearing in mind. So in the group of patients who had a good TME operation, the local recurrence rates, if you were Dukes B versus Dukes C, were identical if the margin was clear and you have a good TME specimen. So what this is telling you is if you've got a terrible operation going on with cutting onto the muscularis propria, then of course nodal status predicts for local recurrence, but it fails to do so once you've got a TME plane operation. And this is in patients who are not irradiated. So what this means is that we have overemphasized our concern about lymph nodes and the risk of local recurrence. It is just not the case. So how do patients get recurrence from rectal cancer if it's not from lymph nodes? Well, there is an obvious pathway and a faster pathway to recurrence than through the lymph nodes. And of course, we've known about this for many decades, but largely ignored it. And that is tumour spread through the veins. Because the veins, unlike the lymph nodes, are not enclosed within the mesorectal package. The veins are free to roam within the pelvis. And tumour can spread through the veins to the pelvic side wall, and no amount of fantastic surgery is going to prevent that patient from getting a pelvic recurrence. And really the best way of controlling that pelvic disease, of course, is from radiotherapy. And we have evidence for that as well. Because without controlling that before surgery, you are allowing that tumour to carry on behaving badly and going into those vessels. And so that's what you end up with, is tumour spread into the liver. So, just move to the next slide. What we have found is, rather than radiological lymph node status predicting for liver metastases within the first 12 months, what we have found is that radiological EMVI status, whether it's on CT or MRI, is the only real major factor for the prediction of liver mets within the first year. And actually, this is the group of patients that needs control. Now, what's very interesting is, unlike the use of chemotherapy, first off, giving chemoradiotherapy to patients with EMVI positive disease does improve their survival rates. So what we see is that if patients who have EMVI positive status at the beginning are given chemoradiotherapy, we see a reduction in the rates of recurrence in those patients. And that the risk of recurrence for both MRI and pathology was the same, but MRI detected twice as many cases of vascular invasion at the end of chemoradiotherapy compared with pathology. So what this means is that you cannot consider pathology, particularly after chemoradiotherapy, to be a gold standard for the risk of recurrence in assessing vascular invasion. So MRI will see these cases much more frequently than the pathology. And we see this here in the published article in Annals of Surgery, where EMVI positive cases were seen in MR in 99 patients, but only seen in half of the patients on pathology, yet the recurrence rates were the same. The risk of recurrence was double that for somebody who has negative EMVI status. So that's also an important piece of information. And what you see is that this is a subgroup of patients who were all EMVI positive to begin with, but if the chemoradiotherapy changed them to become EMVI negative, they had the same survival as a patient who was EMVI negative to begin with. So rather like CRM status going from positive to negative with chemoradiotherapy, those patients improving their outcome, so does this change in EMVI status. And we do not see that with lymph nodes, we do not see that with other factors. It is EMVI, CRM that are prognostically, not only prognostically important, but also prognostically predictive for the use of chemoradiotherapy. So what we see is this change, and what we also see is, unfortunately, chemotherapy alone for this group of patients, who we would have wanted to work because we wanted to avoid radiotherapy, isn't sufficient. And this is probably the only trial so far, but actually it's a sobering trial, because it was the GEMCAD study whereby patients were given chemotherapy with avoidance of radiotherapy for margin states but EMVI positive cancers. And what you see is that the EMVI positive status at baseline still had a high risk factor for development of metastatic disease. So it didn't matter if you changed their status from positive to negative using chemotherapy, their risk of distant and local recurrence was the same. So what that means is that for some reason the radiotherapy, well, we know what the reason is likely to be. The radiotherapy controls the pelvic disease much better than just giving chemo, which is in fact an ineffective treatment for pelvic control. So when you look at what goes on in patients with rectal cancer, I suppose everyone in this room is worrying about this lymph node because it's sitting on the fascia. But they're looking at the wrong part of the image. The right part of the image to be looking at is this. This is much more sinister. This I couldn't care about at all, and I don't even mention this to Paris. In fact, I don't think Paris has even heard when I last called a lymph node, because I ignore them. So, but I don't ignore these. So this is something very bad. This is a tumour deposit growing in a vein, and look what's going to happen with that vein. It's making its way to the mesorectum. It's making its way beyond the mesorectum, and it's making its way to the pelvic sidewall, which we see on that image here. This patient will get a TME operation. That lymph node will be sitting on the fascia. It may or may not be involved, but that is not going to be the cause of that patient's recurrence. This will be the cause of that patient's recurrence. And so, of course, lymph nodes may or may not be positive in this specimen, but the thing that's prognostically relevant is what's going on here. So that's how we've changed the way in which we report. We look for these tumour deposits. And the other piece of evidence, and this again is published evidence, which is that it's now becoming clear that in the majority of patients, probably 2/3, the lymph nodes are not the pathway for tumour spread to distant metastases and to recurrence. So if they are not the cause, why are we so anxious about treating them all the time? Because actually, lymph nodes do a very good job of blocking tumour. They are a hostile environment for cancer cells, but the veins do not provide that kind of barrier to tumour spread. They in fact facilitate tumour spread because they're a fast-moving structure containing nutrients for the tumour and also transport the tumour in a very rapid manner straight to where the tumour is going to get more nutrition within the liver. So whilst the tumour spreads to the lymph nodes and gets stuck there and then even ends up in the bucket after TME operation, the tumour in the veins is free to roam. So if radiologists around the world stopped measuring the size of lymph nodes, we would probably do the best job for our patients, because actually all that we're doing is identifying a group of patients who are mounting an immune response against the tumour. Prognostically on MRI, we have not been able to find evidence that lymph nodes themselves are responsible for either local or distant recurrence. We do not find that. Every time we do multivariate analysis, lymph nodes drop out. They are a bystander. And what we actually know also from some of the pathology studies is we already know that the number of enlarged nodes and the number of nodes is a good prognostic factor. And why should that be? Why should the number of lymph nodes be a good prognostic factor? Well, obviously, everyone knows that if you mount an immune response, you're going to produce more lymph nodes. And they're going to be big lymph nodes, and they're fighting the cancer. So what's the last thing the radiologist should do is measure a lymph node and irradiate them, because all you're doing is blocking an active process that's attacking the tumour. So we shouldn't be so pleased when we have destroyed enlarged lymph nodes with radiotherapy. We should not expect that to be a great success, because all that we have done is eliminated the host's immune response. So I think it's time for us to reevaluate what the mechanisms are for tumour spread in the pelvis. And this is a picture of myself and Iris. I've spent half of my career looking at rectal cancer, maybe in the other half looking at pathology sections and surgical specimens. And someone like Iris is a fantastic teacher, because one of the things that we learn from one another is that we have to be more critical about what we're looking at. We cannot accept a round blob to always be a lymph node. And actually it's not so straightforward. Iris can spend a long time deciding whether something is a lymph node or not. And actually there are a number of criteria to say that it is. So if you see a round deposit, but there's, say, a vascular wall or a capsule that's looking like a vessel, you can't call it a lymph node. If you see a lump of tumour that has no lymphatic material around it, you cannot call that a lymph node. So this is the point, is that we have to understand what is a lymph node and what is a tumour deposit related to vein. Because tumour deposits and vascular invasion are closely related and are a prognostic feature. And so patients who have tumour deposits and vascular invasion do much worse in terms of their survival. And you see their relative risk for recurrence is huge. So the combination of vascular invasion and the manifestation of what extramural vascular invasion does, which is the planting of seedlings, not just within the mesorectum but beyond, is associated with a high rate of recurrence. And it's much more associated with poor disease-free survival, much more so than lymph nodes. So what this means is that you have a mechanism for tumour to spread laterally, for which the only real prevention is the use of chemoradiotherapy. You have a mechanism for the prevention for tumour spread beyond and within the mesorectum. So vascular invasion is associated with tumour deposits, which you see here, but also pelvic sidewall disease. And so that's why we have to be a bit more aggressive about extranodal tumour deposits and ignore lymph nodes to some extent, because actually they're really doing a good job in getting rid of tumour. So I think hopefully from this piece of discussion you will have understood that there are better ways of selecting patients who are at risk of recurrence who require chemoradiotherapy. Tumour spread more than 5 millimetres, patients with EMVI positive status on MRI, patients with vascular tumour deposits or tumour deposits, patients with tumour within a millimetre of the mesorectal fascia, and then patients with the low rectal stage going into or beyond the intersphincteric plane. So who can emit CRT? That's equally important, because who do we want to prevent from having the unwanted side effects of preoperative therapy? Patients who are EMVI negative, who don't get recurrence, patients with tumour spread of less than 5 millimetres, who also don't get recurrence, CRM safe patients, and patients with enlarged nodes. It doesn't matter if they've got enlarged nodes, because if they're EMVI negative, these are patients who are fighting the cancer rather effectively. So the last thing you want to do is irradiate those patients. And patients with lymph nodes close to the CRM, again, pointless treating those patients. And tumour spread with with more than a millimetre clearance to the intersphincteric plane, there is really no point in irradiating those patients. So low rectal cancer stage is part of that assessment, and I haven't really got time to talk about that in detail, but we did the Mercury study. We showed that tumour spread into the intersphincteric plane was a risk factor for CRM involvement. And what we also showed was that patients who had a low rectal cancer did very well without the use of preoperative therapy. There wasn't really an added advantage of irradiating those patients. And so really the patients who you need to irradiate are the other half, where the tumour has gone into the intersphincteric plane or beyond. And there the use of radiotherapy works very well, particularly when there's been a good response. So using the MRTRG response assessment, if they have a good response after chemoradiotherapy, which is about half, then you get a 0 rate of pathological CRM. But actually those patients who don't get a good response, who needed this treatment, the margin positivity rate remains high, and so these patients really need a beyond TME approach if they haven't had a good response. So that's really an important point with low rectal cancers. In the low rectal cancer study, Mercury study, again, lymph node status was not a risk factor for positive margins, but EMVI positivity status on MRI, as seen by all different radiologists, showed a 4-fold increased rate of local recurrence. And we've got the long-term follow-up data, and this was the standalone single factor that predicted for recurrent disease in these patients, which we're going to be presenting very soon. So just a final word on response assessment. This is a whole hour of talking as a separate lecture, but I just want to share with you where we're going with this. We've just launched the TRIGGER trial in the UK, and in fact not just in the UK, around the world. And in this group of patients, what we're doing is stratifying the treatment based on the tumour regression grade response. So if a patient has a good response to treatment as seen on MRI, these patients within a trial setting will be offered an approach of deferral of surgery. Whereas if they have a poor response, then they will be offered further treatment prior to surgery. What we know is that the TRG response is not really related to path-CR. It's not the same thing at all. In fact, 40% of patients with a TRG2 still have tumour at the end, or 60% still have tumour at the end of treatment. But what we're testing in this trial is whether this is viable tumour. And so this is a very different trial to what's gone before in Watch and Wait, because as you can see, about 40% of patients fall into the TRG1 and 2 group, and this is a large group of patients to be following up and monitoring. But on the other hand, there's a lot to be gained from avoidance of surgery in this group of patients. What we also know is that these patients have exactly the same survival as path-CR patients, 90% disease-free and overall survival, and that this group make up about 40% of the patients that we see. So what are we going to do? We're going to randomise patients up and down the country and also around the world. These are the centres that are going to be joining TRIGGER. In fact, Cyprus is joining us, so there's no reason why centres in Greece can't join us too. So these are the centres taking part globally. And the idea is to preserve the rectum in patients who need chemoradiotherapy anyway. So it's not a question that we're going to irradiate them in case they go into complete response. These are advanced rectal cancers with vascular invasion and so on. And this is the group of patients in whom we expect to see a 40% TRG1 and 2 rate. What we hope is that in doing this trial, we'll be able to test prospectively whether or not it is safe to avoid surgery in this group of patients, and whether you can use the MRI to monitor such patients, as well as whether patients and surgeons are willing to put patients through this kind of pathway. The point of this trial is also that we'll be testing the possibility of using chemotherapy as an adjunct selectively in those poor responders. Because, again, if you give a treatment if a treatment's already worked, like chemoradiotherapy's already had a good response, and you've got a TRG1 and 2, giving more treatment to a group of patients who are already going to do very well isn't going to show any improvement. But giving that selectively to the poor responders is going to hopefully show that there might be something better to be gained by waiting a little longer and giving further treatment. So that's the idea of this. The control arm is just what would normally happen, which is high-risk rectal cancer, MRI, surgery, post-treatments, chemotherapy. But the investigational arm will be TRG avoidance of surgery, TRG1 and 2, and TRG 3 to 5 having adjuvant chemotherapy. So there isn't time really to talk about this in a great deal of detail, but the recruitment is going well. We're looking for other centres because we're going to go to phase 3. And our target sample size for this trial is 300 patients to show non-inferiority for the TRG good patients avoiding surgery, and to show an improvement in disease-free survival for the poor TRG response patients in getting further chemotherapy. So it requires a bit of training of radiologists, because not everybody can do TRG assessment, and we accredit the radiologists through training and teaching. And that, I think, is a key area that the radiologists gain some understanding of how to look at these scans. Thank you very much.
Thank you very much for your wonderful talk. Is there any question from the audience? Yes, please.
Wow. I mean, I'm speechless. It was wonderful. The only thing I want to ask is, we are lucky enough to have you in the UK. I'm working now in the UK, actually. So, why all this information and all this change in our management, in your management at least, of rectal cancer hasn't passed on into NICE guidelines? What's the problem?
I think they've, thankfully, Rob Glyn Jones, I don't know if he's in the room, has incorporated many of these into the ESMO guidelines. The NICE guidelines were written in 2011, and it's now 2018. And their process doesn't enable very rapid update of NICE guidelines, so we're always about half a decade behind. And that is the problem. So by the time the NICE guidelines are written and published, probably Trigger will be finished, Comet will be finished, all our trials showing these new bits of information to change practice will be, again, another 5 years ahead of what even the current NICE guidelines. So there's always going to be a lag. And that's why they're called guidelines, because they essentially set a minimum standard that people should be following. But you should still, in terms of your local MDT policy, should think about your own practice and the evidence base that is published, and use that.
Thank you.
Yes, please.
Gina, I've been singing from your Bible for a very long time. Sorry, I've been singing from Gina's Bible for many, many years. Indeed, I discovered her long ago. But there's one thing that's changed in what I will say in future, and just confirm that I'm right, that even N2 disease, in the up until now, the N2 disease, more than four or more nodes, has been an indication for chemoradiotherapy even at the Marsden. That is no longer true?
So, yeah, I mean, essentially, Bill, and Paris will back me up on this, I've stopped reporting lymph nodes. I've just stopped reporting. They've noticed in the MDT, they said, well, what about the lymph nodes? And I just say no comment. So, so that reason, we don't, they won't find cases with it that I've reported N2. They won't find them.
Sorry, just to say, but in fact, the really nasty looking lymph node will have been reported as the MVI. That's the point.
Precisely. So these so-called, I think what's changed is the fact that the new TNM classification allows us to use this phenomenon of tumour deposits and extranodal spread and discontinuous vascular invasion as an entity upon which to back up the use of both adjuvant chemo but also neoadjuvant therapy. So our emphasis has just shifted, that we ignore the nodes but instead look at the vascular deposits.
No, you are not allowed to say anything. Thank you for your lecture. Sad you weren't here yesterday, because you know all the Germans talk about all the lymph nodes, and we don't look at them at all. We don't look at them at all.
You know what a lymph node is?
Of course we know what a lymph node is, but we don't. We know that you can flip the coin, and probably what they are reporting as lymph node might be vascular invasion. Anyway,
Correct.
Instead, the big problem. And therefore, I would recommend all of you to take part in this Trigger trial. I don't care if it works or doesn't work. Many trials fails, but the most key thing is that you get the training. So you get the training. So when you listen to what Gina is saying, you can't expect that you can get the same service at home unless you have been part of a trial where you have controlled and checked the quality. So go into the trial, because then you have a good radiologist.
Thank you, Simon.
Can I just have a comment on the same topic? I think your lecture is brilliant, and I think your ideas are very interesting. Although I feel I cannot just buy it completely. And I think there's a risk, because if you don't have really skilled radiologists like yourself, if you say you should not report lymph nodes, I mean, there's a risk that they will not report tumor deposits because they think that's a lymph node, and that may mean that you understage the patient. So I think there's a risk here that they tell the radiologists don't report lymph nodes because they can miss tumor deposits, if you're absolutely sure.
Yes, I think the key thing, you're absolutely right, is as a radiologist that's ignorant of both lymph nodes and vascular deposits is going to do a bad job. But telling them to report lymph nodes, rather like irradiating a patient in case the surgery is bad, is the same as saying to radiologists, well, overstage everything. Overstage everything because you never know what you're missing. That is not the solution.
No.
I know, but understaging is not the solution either.
So the solution is to stage using proper objective criteria. So if somebody says to you, I see an enlarged lymph node, immediately alarm bells should be ringing in your head, because what are they doing even measuring the size of that node? What they should have been saying is, this is tumour in a vein, this is tumour in a node, this is tumour growing discontinuously. We need something more precise. And it is not difficult to know the difference between a vein and a node. They are very straightforward to see. And my Professor Zinos has very kindly given me a lecture this afternoon on radiomics. And this is a problem with radiology, that we jump onto the next big thing. We jump onto diffusion-weighted imaging, we jump onto contrast, we jump onto measuring things, when actually looking critically at the image, understanding the pathology is the key thing. And if we invested a quarter of the amount on looking at things properly instead of looking at the next future horizon, future science, we would be much better doctors as a result.
I still think it's challenging that you say that all the lateral lymph nodes, for example...
No, that's not what I'm saying.
No, it's not what I'm saying. What I'm saying is that when tumour grows into a vein, that's a bad thing. When that happens, yes, you will get lymph nodes involved. Yes, you will get spread to the pelvic sidewall. But the way in which that has happened has been through the vascular channels. That a lymph node itself is probably not going to be the major cause of that patient's demise. And if you carry on measuring lymph nodes and worrying about every lymph node you see, you will miss the main problem, which is the vascular invasion and the discontinuous tumour deposits. That's all.
And I would like to support really Gina. I mean, you're so old-fashioned, Torbjörn. I mean, you think that a fool with a tool should still be a fool.
You buy everything new.
No, I don't buy anything. I buy quality. And I'm saying, it might be that her theories are wrong. It doesn't matter. It doesn't matter. The real thing, and that has been shown over and over again, if you take part in trials, the quality goes up.
I agree completely, but I'm not
thank you.
sure.
So go for quality, Torbjörn. Instead, you're getting so much grey hair and old-fashioned.
Can I also add into this one? Because obviously we have a problem with the nodes, but we want to know whether at least they are positive or negative. I agree with Gina that maybe nodes are not so important, but we need to know that they are positive so that the oncologists guide their treatment, because ultimately the treatment will be guided by whether it was node positive or negative before chemoradiotherapy. Vascular invasion also is important, we need to know, but most of the radiologists don't know how to report it, so we need to have a halfway house. So
I'm going to cut you short.
That's what we are arguing, you see. I tend to agree with Torbjörn, because it's a pragmatic approach of what happens in the real world. Real world don't know how to report it.
So when I hear the word pragmatic and real world, major alarm bells, let me finish Paris, major alarm bells are going on in my head, because all that is a shortcut for, we're not going to bother to improve the standards. It is not possible for radiologists to learn how to look at EMVI. Every piece of data I showed you is not from me, it is from radiologists taking part in these trials. In fact, even the Mercury 2 is from Sigmar, looking at his MR scans by himself, because he hasn't got a radiologist. But the point is, it is teachable, just like TME is teachable and trainable. And to say we can't do it, let's just carry on measuring lymph nodes, is the wrong thing to do. So the correct thing to do is get your radiologist trained. I do 4 workshops a year. Every single one of those radiologists will, from now on, be accredited. And that means you will be safe. You will make your decisions safely. That we have not run into trouble with me ignoring lymph nodes in those MDTs. The radiotherapist will treat the pelvis entirely when there is EMVI positive spread. They will treat the fields. They will treat what they can see. But actually, many of these tumour deposits, many of these areas of disease spread are not even macroscopically visible at the time of surgery. And so many of the recurrences that we see, you could not predict, but you do prevent by giving preoperative therapy. So it's not a question of saying that lymph node is positive and that one is negative, so I'm going to not irradiate that, I'm going to irradiate that. This patient has EMVI positive disease, there is a risk of spread anywhere within the pelvis, we are going to irradiate the pathways of spread as a preventive measure. And that's why I disagree with Paris.
This is what happens every month.
But he goes quiet.
Okay, I think we're going to have more of this actually this afternoon. You are here to give them.
Yeah, I'm talking about not radiomics this afternoon.
Great. We're going to move on to the next section.